This lecture will go over hyperthyroidism. Hypothyroidism is excessive thyroid hormone secretion from the thyroid gland. The symptoms of hyperthyroidism are called thyrotoxicosis, regardless of the origin of the thyroid hormone. Thyroid hormones increase metabolism in all body organs, producing many different symptoms. The excessive thyroid hormones stimulate most body symptoms, causing hypermetabolism and increased sympathetic nervous system activity. So again, with hyperthyroidism, the patient's metabolism is being turned up, right? And we're also going to see what we see in the patient with increased sympathetic nervous system activity. So remember, sympathetic nervous system, that's your fight or flight. So metabolism's up, and we're going to see the symptoms of, or the signs of fight or flight being engaged within the patient. So knowing that, then think about how hyperthyroidism would affect the cardiac system. So in terms of heart rate, stroke volume, blood pressure, cardiac output. How do you think hyperthyroidism would affect those things? Would it turn it up or turn it down? With hyperthyroidism and the engagement of the sympathetic nervous system and the increase of metabolism within the body, everything's going to be turned up. So we'd have increased heart rate, increased BP, increased cardiac output, and I forget if there was another one, but if there was, I think it was stroke volume. That's going to be increased also. Protein buildup and breakdown are increased, but breakdown exceeds buildup, causing a net loss of body protein, known as negative nitrogen balance. Glucose tolerance is decreased, and the patient has hyperglycemia. Fat metabolism is increased, and body fat decreases. Although the patient has an increased appetite, the increased metabolism causes weight loss and nutrition deficits. The most common cause of hyperthyroidism is Graves' disease. Goiters are common in Graves' disease. They occur due to an increase in the number of glandular cells, which enlarges the thyroid gland, forming a goiter, and overproduces thyroid hormones, resulting in thyrotoxicosis. In Graves' disease, all the general symptoms of hyperthyroidism are present, and you have a nice key features chart in your textbook for the key features of hyperthyroidism you're going to want to review. In addition, other changes specific to Graves' disease may occur, including exophthalmos or abnormal protruding of the eyes, and pre-tibial myxedema, a dry, waxy swelling on the front surfaces of the lower legs that resembles benign tumors or keloids. Hyperthyroidism caused by multiple thyroid nodules is termed toxic multinodular goiter. The nodules may be enlarged thyroid tissue or benign tumors. Hyperthyroidism can also be caused by excessive use of thyroid replacement hormones. In terms of assessment, many changes and problems occur because hyperthyroidism affects all body systems, although changes may occur over such a long period that patients may be unaware of them. Record age, gender, and usual weight. The increased metabolic rate affects nutrition. The patient may report a recent unplanned weight loss, an increased appetite, and an increased number of bowel movements per day. Remember, the patient with hyperthyroidism is in a hypermetabolic state. A hallmark of hyperthyroidism is heat intolerance. The patient may have increased sweating, even when environmental temperatures are comfortable for others. They may wear lighter clothing in cold weather. They may also report palpitations or chest pains as a result of cardiovascular effects. Ask about changes in breathing patterns because dyspnea, with or without exertion, is common. Your key feature box points out again that the patient will have an increased metabolic rate, experience heat intolerance, low-grade fever, and fatigue. GI symptoms include weight loss with increased appetite and increased stools. The negative nitrogen balance is again related to the breakdown of protein. Cardiopulmonary symptoms include increased systolic blood pressure, increased heart rate, tachycardia, dysrhythmias, chest pain and palpitations, rapid shallow respirations. Neurologic symptoms include problems with the eyes, blurred or double vision, eye fatigue, increased tears, red conjunctiva, photophobia, exophthalmos, eyelid retraction and eyelid lag, globe lag, hyperactive deep tendon reflexes, tremors, and insomnia. Reproductive symptoms include amenorrhea and increased libido. Other symptoms include diaphoresis, fine, soft, silky body hair, thinning of scalp hair, smooth, warm, moist skin, goiter, enlarged spleen, muscle weakness, and wasting. Again, please be sure to review the key features chart for hyperthyroidism on your own. Here's a visual for hyperthyroidism. You can go ahead and pause the video and review those signs and symptoms that are illustrated there. Here's a visual for exophthalmos. And then a visual for goiter, what a goiter looks like. As previously stated, visual changes may be the earliest problem that the patient or the family notices, especially exophthalmos with Graves' disease. Ask about changes in vision, such as blurring or double vision and tiring of the eyes. Ask the patient about changes in energy level or the ability to perform ADLs. Fatigue and insomnia are common. Families may report that the patient has become irritable or depressed. Ask about changes in menses because amenorrhea or a decreased menstrual flow is common. Initially, both men and women have increased libido, but this changes as the patient becomes more fatigued. Ask about previous thyroid surgery or radiation therapy to the neck, because some adults remain hyperthyroid after surgery or are resistant to radiation therapy. Exophthalmos is common in patients with Graves' disease. The wide-eyed or startled look is due to edema in the extraocular muscles and increased fatty tissue behind the eye, which pushes the eyeball forward and may cause problems with focusing. Pressure on the optic nerve may impair vision. If the eyelids fail to close completely and the eyes are unprotected, they may become dry and corneal ulcers may develop. Observe the eyes for excessive tearing and a bloodshot appearance. Ask about sensitivity to light or photophobia. Two other eye problems common for hyperthyroidism are eyelid retraction, eyelid lag, and globe eyeball lag. In eyelid lag, the upper eyelid fails to descend when the patient gazes slowly downward. In globe lag, the upper eyelid pulls back faster than the eyeball when the patient gazes upward. During assessment, ask the patient to look down and then document the response. Observe the size and symmetry of the thyroid gland. Palpate the thyroid gland to assess its consistency. In goiter, a generalized thyroid enlargement, the thyroid gland may increase to 4 times its normal size. Goiters are common in Graves' disease and are classified by size. Not all patients with a goiter have hyperthyroidism. Bruits may be heard in the neck with a stethoscope. Again, the cardiovascular problems of hyperthyroidism include increased systolic blood pressure, tachycardia, and dysrhythmias. Usually there's a widened pulse pressure with the diastolic pressure being decreased. Inspect the patient's hair and skin. Fine, soft, silky hair and smooth, warm, moist skin are common. Patient may notice thinning of scalp hair. Muscle weakness and hyperactivity of deep tendon reflexes are common. The patient may appear restless, irritable, and fatigued. In terms of psychosocial assessment, the patient often has wide mood swings, irritability, and decreased attention span and manic behavior. Hyperactivity often leads to fatigue because of the inability to sleep well. Some patients describe their activity as having 2 modes, either full speed ahead or completely stops. Ask whether he or she cries or laughs without cause or has difficulty concentrating. Testing for hyperthyroidism or lab assessments involve measurements of T3, T4, and TSH. Antibodies to TSH receptors are measured to diagnose Graves' disease. Please review the laboratory profile chart 63-2. A thyroid scan evaluates the position, size, and functioning of the thyroid gland. Radioactive iodine is given by mouth, and the uptake of iodine by the thyroid gland is measured. The half-life of radioactive iodine is short, and the radiation precautions are not needed. Pregnancy should be ruled out before the scan is performed. Radioactive iodine uptake is increased in hyperthyroidism and can be used to identify active thyroid nodules. Ultrasound of the thyroid gland can determine its size and the general composition of any masses or nodules. An ECG may be performed to assess for dysrhythmias.